Hi everyone, and I welcome you to the Labs to Clinic series. And in this very special session, we are going to discuss about neonatal sepsis. If you have joined us, please come and say hi in the chat box. It's always very nice to see all of you. And in this series, we are attempting to integrate your knowledge of microbiology with your knowledge of medicine, pediatrics, and the kind of patients that you're actually going to see. So today we are going to discuss neonatal sepsis. Basically, whenever you have a neonate, which is obviously less than 28 days of birth, a small child, how do you identify and screen for sepsis? What are the most important microbiologically, important infectious agents or microorganisms which are responsible? And also, very importantly, what to do when the blood cultures come out to be negative. So I hope that all of you do understand the difference between sepsis and bacteremia, etc. Whenever there is bacteria in the blood, we call it bacteremia. When the body starts reacting against that bacteria, causing inflammation, increasing the inflammatory markers, recruiting the WBCs at that site, that is when we call it as sepsis. And what is septic shock? When all of this inflammation leads to end organ damage and organ failure and decreased blood pressure, that is when we call as septic shock, right? So hi everyone who has joined and who are obviously commenting here. So let's start the session. So I have a small little series, a case wherein you have a child. The child is just 2 days old. So of course it's a neonate because it's less than 28 days, right? And it's a late preterm. Okay, the weight is 2 kgs and delivery is NVD at a peripheral center. Then, sometimes at a peripheral center, you can imagine that there might be some breaches in the infection control, but that's not a necessity. Poor feeding since birth, lethargy, and episodes of apnea, and the child is cold, hypothermic, temperature stability is not there. The major complaints which the mother is telling is that there is some feeding issues. Okay, poor feeding since birth, there has been inadequate feeds, and the temperature is also not controlled. There is episodes of apnea, there is respiratory, probably the patient is also in respiratory distress. That is what you need to rule out now. And lethargic. So it's a sick looking baby. Okay, a sick looking baby has come to you. When you took the maternal history, there was a prolonged rupture of membranes, prom. This is very important to elicit that a prolonged rupture of membranes of more than 24 hours increases the chances of introducing a infectious agent to the baby via the mother's birth canal, right? And there is maternal fever was also present. Foul smelling liquor was present at the time of birth. Inadequate interpartum antibiotics. I mean, this is a history that is very difficult to elicit from you, from the mother, but if you get access to the notes, then probably you can find out. And no antenatal GBS screening also, because we all know that the group B streptococcus is what resides in the birth canal of the mothers, right? It is a part of the vaginal flora. That is why it becomes the most important cause of neonatal sepsis also worldwide. So the most common cause worldwide is group B streptococcus, okay, GBS. So all of this is pointing towards a neonatal sepsis kind of a situation. At least a neonatal infection, this is pointing me towards, because it's a day 2 old baby. Okay, and there is definitely a sick looking child with some problems, some infectious etiology, and there is also significant intrapartum or perinatal history. That is, at the time of birth there was prolonged rupture of membranes, so probably there could have been chorioamnitis in the mother, right? Examination findings: the baby is 35.5 degrees Celsius temperature, 170 heartbeat, 68 oxygen saturation is less, and this is what we want to look at. Capillary refilling time is prolonged, more than 3 seconds. Prolonged capillary refill time in the babies is often a sign of infections, right? Tone is hypotonia, and therefore it is a sign of poor perfusion. Poor perfusion. So it is telling me that the organs are not getting proper, the blood supply is not happening. So all of this is kind of giving me a signal that I might be dealing with a case of neonatal sepsis. Why have you suspected neonatal sepsis here? Because A, clinical features are present. What all clinical features? Lethargy, poor feeding, apnea, and temperature instability. All of these are your pointers towards it. Plus, risk factors are also present. What risk factors? PT, prom, maternal fever, and foul smelling liquor. Probably chorioamnitis was present. So you have two important things to now start suspecting neonatal sepsis, which is a risk factor as well as clinical features. So you know that the neonatal sepsis can be classified into two. It's the early onset and it's the late onset, eons or lons. Early onset neonatal sepsis, that is when infection happens less than 72 hours after birth, and late onset is after 72 hours. So this is a day 2 of life baby. Day 2 of life. So where do you think it's going to get classified? Early onset neonatal sepsis, right? And if it was more than 72 hours, it would have been late onset. The most common organisms implicated are group B streptococcus and the gram-negative such as E. coli and Klebsiella, and a GPB which is Listeria monocytogenes. All over the world, it's GBS which is most common, but in India and in low middle income countries, it is always the GNBs, the gram-negative bacilli are always the most common. So Klebsiella and E. coli are the most common in India in low middle income countries, right? For late onset sepsis, it is majorly gram positives, some gram negatives, and also candida, which is a fungus, becomes an important cause for late onset. Why is that the cause? Why is that the case? Because your early onset within 2 days of life, baby has not even been significantly exposed to the world. What is one environment that the baby has seen for the longest time in early onset? The maternal environment. So obviously, the organisms which are a part of the normal flora of the birth canal of mother, they are going to be responsible for early onset neonatal sepsis. And for late onset, it can be hospital acquired through the hospital, acquired from the nurses, from the doctors, from the other babies, from other mothers. Also, if the baby has gone home right after birth, then from the community, from the home environment, right? That is why the group B streptococcus is going to be more common in early, because it is part of normal vaginal flora, whereas the GNBs and GPCs are going to be more important when we are talking about community acquired, right? You know, obviously, what are the clinical features associated? The patient is sick looking, patient is lethargic, inability to feed, respiratory distress, seizures can also happen, and abdominal discomfort. Now, this neonatal sepsis, since the infection is in the blood, it can go on to reach any organ. It may involve some organ first. So the most common cause of early onset sepsis is actually pneumonia. So in the child, the focus of infection will start forming in the lungs. So from the pneumonia, it will go on to becoming a sepsis involving the entire bloodstream, right? So also it can go on to affect other organs. In severe cases, it can involve the brain and lead to meningitis. In such a scenario, the baby can also present with seizures to you, right? So all of this we have seen is present, not the last part, but lethargy, inability to feed, and apnea, and a sick looking child is what we have encountered. That is why we thought of neonatal sepsis. So of course, this is just a comparison. Early onset is from the mother. Who's the source of early onset? The source is mother in early onset neonatal sepsis, whereas the source in late onset is the hospital or even the community, the home environment. From the outside world, the baby is going to get this infection. Of course, you see group B streptococcus, then your GNBs and Listeria. Of course, other causes can also be there. You can never rule out. It's about the most common examples only. Risk factors of early onset. Maternal GBS colonization. There is no reference. Our mother does not know whether she was a colonizer or not. Chorioamnitis. We have seen chorioamnitis could have been present here because of the prolonged rupture of membranes. Yes, prolonged rupture of membranes, in fact, may becoming a risk factor for chorioamnitis. Preterm birth and multiple gestations from the mother also. So in our baby now, the clinical features as well as the risk factors are all present. So it can be early onset neonatal sepsis. Just to tell you, community acquired and hospital acquired, late onset sepsis. So of course, you have most importantly the GPCs and the GNBs. Again, in the low middle income countries, it is going to be the GNBs which are more important for India and low middle income countries. In the Western world, it is the GPCs which are more important, especially Staph aureus and cons. Cons has now been renamed as OSS, other staphylococcal species, right? Okay, let's continue. So sepsis screen is what you have to do. So basically, what will you do in your patient? If you have clinical features plus there are risk factors, then the next step that you have to do is a sepsis screen. That is, you want to screen for the presence of neonatal sepsis. Now, uh, these are all the indices that you will look at. Number one is the total leukocyte count, the TLC. Now, in this case, we know that the dictum is that if there is an infection, there is going to be raised TLC. But in this scenario, it's going to be, lesser or decreased. There's going to be leukopenia. And in our patient, it was 3.8, 3800. Okay, so there is leukopenia. Then you look for absolute neutrophil count, ANC. Very, very important is ANC. That is also low. So this is also abnormal. This is also abnormal. Two indices I have seen are abnormal. Then what is IT ratio? It is very important. Immature to total neutrophils. How many neutrophils are immature and how many out of total neutrophils, how many are immature? That ratio is also deranged. Increased means more and more abnormal and immature neutrophils are found. That is also positive. CRP, you know, C-reactive protein is a marker of inflammation in the body. If that is raised, you know there is some kind of infection or inflammation. That is also raised. Micro-ESR again is a marker of the same. Platelets result showcasing thrombocytopenia. Then blood culture is a very important microbiological parameter that you need to have. So all of these parameters become a part of your sepsis screen. So first of all is the blood work involving the total leukocyte count, absolute neutrophil count, immature to total neutrophil ratio, CRP, micro-ESR and platelets. Finally, you have to send a blood culture because you want to detect bacteremia because you are suspecting sepsis in this patient, right? In my patient, there is no growth at 5 days. Blood culture has come out to be negative. So what is this? Now, the rule is out of all of these, except the blood culture part, all of these parameters, if any two are positive, it is a positive sepsis screen, any two. So here I have more than two positive. So I can say that the sepsis screen here is positive in my patient because more than two positives I have seen. Yes, more than two parameters are positive. So now what? Why is the blood culture negative? Does a negative blood culture mean no sepsis? Does a negative blood culture mean that there is no bacteremia, there is no sepsis? So, of course, the probable early onset neonatal sepsis is my diagnosis. The next thing that I have to do is immediately start on empirical antibiotics. We will just see what empirical antibiotics we use. We basically use broad spectrum gram negative and positive antibiotics so as to give maximum coverage because this is empirical. This is not culture guided. This is not antimicrobial susceptibility test guided therapy. Okay. But first, before even starting the antibiotics, the first thing that you have to do is send blood cultures, send urine cultures, send CSF culture and also do a chest x-ray because you want to find out any focus of infection inside the body, right? So you have to send the blood culture. It is mandatory because you want to pick up any bacteremia. Also, you want to culturally prove sepsis. You have to also send CSF and urine cultures because if at all there is meningitis or any UTI which is a focus of infection, then that can be caught and meningitis can be caught. So that will also become a full-blown meningitis or a full-blown severe neonatal sepsis. Then chest x-ray, of course, to catch any pulmonary infection involvement. You want to send all of this before you start the antibiotics. That is very, very important because if you send these cultures after starting antibiotics, then the yield of bacteria decreases, then all the reports will come out to be negative and you will not go anywhere with your diagnosis. So you have to, in order to help the labs, help you reach a diagnosis, you have to help the labs by sending the sample at the right time. So before you start all of this, collect the patient samples, send to the lab and immediately start empirical antibiotics in the patient. Why blood culture was negative in my patient? So of course there can be technical and lab related reasons and there can also be organism related reasons. What are the technical lab related? The volume was very, very less. The amount of blood that you collected and put in the blood culture bottle was very, very less. So false negative can happen, meaning there was not enough sample for the bacteria to be able to grow in the 5 days time that I have kept it inside the incubation. Okay. So if you will collect very less amount of blood, nothing is going to grow. Delayed transport, or probably you have refrigerated the sample, inadequate incubation, and single culture bottle is associated with low sensitivity. So always in the patients of sepsis, we say that more than 2 or at least 2 blood cultures collected from 2 different sites is what we need to send, because that increases the yield, that increases the chances of getting a positive blood culture by more than 80 to 90%. Okay, if you send one blood culture bottle, there is almost 50 to 80% chance that some bacteria will grow and you will get a positive report. If you send 2 blood cultures from 2 different sites, then the chances increase up to 90%. And if 3 are sent, then the chances increase up to 95 to 99%. It is likely that you will not miss a bacterial pathogen. And in that scenario, if a negative culture is coming, probably that's a true negative. Okay. So this is what the blood culture bottle looks like. You have seen the automated Bactec bottles, and this is here a small little manual blood culture bottle. So it is very, very important in the clinical practice to make sure that the bottle that you have chosen is a pediatric blood culture bottle. So you see this bottle here, it is written PEDS plus. PEDS plus means this bottle is for pediatric patients. What's the difference? The difference is in the golden ratio. What is the golden ratio? Now this is very important for the MBBS students. What is the golden ratio which you have to maintain in blood cultures? 1:5. What is the 1:5 ratio? Blood is to broth. Blood is to broth ratio. So it can be 1:5 or 1:10. That means if you are taking 5 times the amount of broth, 1 parts of that has to be blood. Okay. So if you are using 5 ml of broth, 1 ml of blood needs to be put inside it. Or 10 ml of broth, 1 ml of blood needs to be put inside it. So if you're using a bottle with 50 ml of broth inside it, at least 5 ml of patient's blood needs to be added. Why? Because what is the broth that we use in this? You know, the brain heart infusion broth, which is the BHI broth, or the trypticase soy broth. The trypticase soy broth or brain heart infusion broth. I always tell you to remember big heart and chota brain. So it has the cow has a big heart, so it has the beef heart and the calf brain in the brain heart infusion broth. So we have infused both the things. And trypticase soy broth can also be used. What are these? These are enriched medium. These are enriched medium, MBBS students, right? So they are going to enrich any bacteria which is present inside the sample of the patient. Because such a big patient, okay, we are talking about a neonate, that's a small baby, but usually the dictum is that the size of the patient versus the size of the sample that you're collecting, you need to make sure that whatever little blood that you've collected from the body, even if any small amount of bacteria is present in it, you enrich it so much that it starts growing on your culture plates. That is why this golden ratio has to be maintained. In a scenario that you miss out on this golden ratio and you send very less amount of sample, there can be false negative results which can happen. Okay. This you have seen. This is a manual bottle. This is an automated blood culture bottle. You know this. That is how the collection needs to be done. First of all, you have to sterilize the caps of the bottles, because that is where you're going to insert the sample. The bottle should be at room temperature. If you have refrigerated the bottles, take them out, let them come on to the room temperature, and only then insert the blood, because the bacteria is not going to be able to survive the cold temperature of the fridge, okay, the 2 to 8 degrees Celsius. So first you have to let the bottles come to room temperature, then only try to fill them with patient's blood. That is how you collect with a closed system. Okay, if it's a neonate, small babies, then so much of pressure their veins are not able to take, then you can collect with the help of a syringe. Then of course you have to insert it inside the blood culture bottles. This is here a automated blood culture bottle, this is a manual blood culture bottle. Does not matter, the ratio has to be maintained. Okay, That is how you know the ratio has to be maintained. In a blood culture bottle, you can see this is up till where the broth is there. So you count that this is around 50 ml of broth. So up till here, 10 ml of blood is what needs to be filled in this bottle. So when you fill the bottle with blood, you have to mark up till where you have filled it. Otherwise, it's going to get rejected by the laboratory. This is supremely important. So very important topics for MBBS students covered. Sterilize the caps, collect the sample, fill in the 1:5 or 1:10 ratio, and then send to the lab. If you cannot immediately send it to the lab, then you either leave it at room temperature or you incubate these bottles at 37 degrees Celsius. Now, this is the scenario when you want to do aerobic bacterial cultures, because this itself is an enriched medium, na? So this sample collection bottle itself acts like a culture media. It is a culture media. So the till the time you're leaving the bottle at room temperature, or in the ward itself, if you have the facility, you're putting it inside an incubator, you only have started the process which the lab is going to do. Incubation has started because the broth is already inside. So whatever little bacteria is there, it will start growing. But if you put it in the refrigerator, you have simply wasted the patient's blood. Okay. This is for aerobic bacterial cultures. What if you're also suspecting some anaerobic culture? In that scenario, it is important to collect from 2 venous puncture sites. So try to take out from 2 separate veins. If you can't take out from 2 separate veins, try to take out from the same site 2 hours apart. Okay, so all of this really helps in coming to a true diagnosis of neonatal sepsis. Causes of culture, negative neonatal sepsis. One is the lab based. So for that, we have just understood the entire blood culture system. Then there can be, of course, bacterial causes, bacteria which are not detected in routine cultures. So the fastidious diva organisms, which require enrichment, which require other special culture media to grow. Intracellular organisms, viruses, fungus, if these are the causes, then it becomes problematic. You know, we have just seen for the late onset, candida is an important organism. So mostly it grows after 5 days. Some bacterial bottles, they don't support the growth of candida. Then in that scenario, then viruses, very, very important. Enteroviruses such as the Coxsackie virus, the herpes simplex virus, they can all lead to neonatal sepsis also in children. They very easily succumb to these infections. In those scenarios, we will not be able to grow them on a blood culture bottle. So if a blood culture report is coming out to be negative, it does not mean that infection is not there. It could be a fastidious bacterial infection, it could be a viral infection, it could be a fungal infection, or it could be non-infectious causes. Then, of course, technical and pre-analytical we have just seen, right? So, all of these different things which can happen, if a fastidious bacteria is there, probably some uroplasma or mycoplasma is there, very, very difficult to grow in the labs. In that scenario, you should want to go for PCR-based detection methods. Partially treated bacteria, the common ones only, GBS, E. coli, Klebsiella, which grow very easily on bacterial blood culture, but they were partially treated. So their growth has been hampered. Their morphology has been changed. Antibiotic pressure is there. So they're not able to grow a lot in culture. Does not mean they're not present inside the patient. Okay. That is why it is important to send it before starting antibiotics in the patient. Anaerobes, such as bacteroides or Clostridium. Now, anaerobes need absolute anaerobic culture environment. Most labs are not equipped to culture anaerobic bacteria. So they are also not going to grow in the normal aerobic bottles. Mycobacteria, highly fastidious, need special culture media. Also, extracting microbacteria inside blood is never going to be possible. So always PCRs are preferred. Spirochetes, fungal such as Candida, viral HSV, enterovirus, cytomegalovirus, and parasitic such as malaria, toxoplasma. So many causes can happen. So it is very important that then you go for PCR based panels. The 16S rRNA PCR, I always tell you, is the first detector of a bacterial infection. If nothing is coming positive and still you are suspecting that this could be bacterial meningitis, sepsis, because that is in fact the most common infectious cause of neonatal sepsis, then a 16S rRNA tells you that, okay, some bacterial infection is there at least. It won't be able to identify, but it is a marker of bacterial infection. Multiplex sepsis panels. What is multiplex? Multiplex PCR. Basically, in a single PCR, you are getting information about many different panel of microorganisms. So it can tell you about bacteria, virus, fungus, parasite in a single PCR. Then serum procalcitonin is another very important marker of a bacterial infection. Okay. So all of these tests are alternatively what you need to go for in case the blood culture comes out to be negative. So here what am I dealing with then? I am dealing with a culture negative. A culture negative sepsis screen positive early onset neonatal sepsis. This is what I am dealing with over here. So of course I have to start empirical. What were the antibiotics? Ampicillin and gentamicin. Or alternatively, you can use any third generation cephalosporin plus amikacin or gentamicin. Depending upon what your hospital policy, this can be decided. Preferred is ampicillin or gentamicin, right? Then modify based on culture response and markers. If you have procalcitonin raised or if you get positive blood cultures, then depending upon the AST report of that, you have to modify the treatment, and the duration is usually for culture negative sepsis, it is 7 days, around 1 week's time. So in case your clinical features are there, risk factors are there, sepsis screen is negative, then 3 days of antibiotics. Sepsis screen positive, culture negative neonatal sepsis, 7 days of antibiotics. Culture is also positive, 14 days of antibiotics. Any complications such as meningitis, take it up to 3 weeks, 21 days. Okay, that is the dictum of treatment of neonatal meningitis. So in summary, the approach is that a culture negative neonatal sepsis has to be approached in a stepwise manner where blood culture is mandatory and sepsis screen has to be positive. Then you have to modify depending upon the blood culture. If blood culture is positive, you simply go ahead and do the AST targeted therapy, and if it is negative, you go for PCRs and molecular diagnosis. Targeted testing, especially for the viruses, is needed, and then you of course you have to rule out non-infectious causes if the entire panels come out to be negative. So the take home is that a blood culture negative sepsis does not mean it is a non-infectious neonatal sepsis. Okay, that was the gist of today. Of course, this is where you can reach out to me in case you have any queries. I always tell my students to just stay in the game. It is not important to, really push yourself in the corner. Just try to stay in the game. Just listen to the lectures and keep yourselves updated. Thank you so much, guys, for joining in. I will see you soon next time with the next very interesting case of labs to clinics, where we're going to integrate your knowledge of microbiology with knowledge of medicine and other clinical subjects. Thank you.